show it does not go.
It just shows like that.
Right,
exactly.
right.
So I'm going to use my.
Okay, so your talk is first, right?
My talk is first.
Okay， 那先接他的台吧，接他的电脑。
他接自己的电脑。
对，因为不然他想要一面看一面讲，那我们现在找不到那个。
一面看一面讲，可是我们好像只能接一台。
我知道，它是一台，但是它荧幕可以分两面。
And then I just advance
可能要等3-5秒。现在是看。
Like this.
Go up and down. Like
Yes.
So we can go to the first slide. There. That's the first.
第一个吗？
这样子。
I'm going to use this as well.
不好意思哦，我提醒一下，那个大会有给各位袋子里面有一包这个软硬币，它就帮你放说明书，所以这包不要丢掉。你假如说哪里酸痛，你可以试试看，但是APR没有用。所以说呢，它的吸管是吸收你的氧化性，然后整个是反射有收的效果。啊，这个可以试。我因为大会不好意思，忘了放说明书在里面，你可以对这个那一包100块啊，这个你可以看知道。谢谢哦。
And I can just control here.
Sure. Okay. All right.
So I think I'm.
Did that?
think
Is it yours or?
That's mine. So I can keep that then.
Sure.
Should I have some seat? Should I have a seat down there? Introduced?
现在要开始了吗 Okay, so we can sit down first.
Okay.
So, good morning, our dear colleagues. In this session, there will be two very important persons presented. Both of them are the most important person in the field of internal medicine around the world. The first one topic will be presented by Professor Nitin Damle. Professor Damle is currently the president of American College of Physicians. He is past president of Rhode Island Medical Society and past president of medical staff of the South County Hospital Healthcare System and a member of the Board of Trustees. He also serves as clinical assistant professor of medicine at the Airport Medical School of Brown University. He has authored several peer-reviewed articles and writes medical columns and commentary on healthcare-related issues. Today, he will give us a topic entitled as Cancer Screening Guidelines 2016 to 17. Professor Nitin, please.
Well, good morning, everybody. It's a pleasure to be here, and it's an honor actually to be here. So it's been a wonderful time for my wife and I, who've been here for about 4 days now, and it's our first trip to Taipei, but I'm hoping that it's not also our last. So look forward to coming back at some point. So what I'd like to talk to you today about is cancer screening guidelines for 2016 and 17, the why, when, and who. That's my credentials, and I have no relationships that are of any substance as far as conflicts of interest as far as this talk is concerned. So what I'd like to do today is to do three things basically, is to review the evidence for the screening recommendations and then review the guidelines for screening the 5 most prevalent cancers. And what I'd also like to do is use a little bit of a case-based approach. So I'm going to mix in some questions, some cases, and then some questions. And I'd love to have your audience participation just by a show of hands as to which option you think is the best answer. And then we'll talk about it after that. So the 5 cancers that I'm going to talk about are colon, breast, cervical, lung, and prostate. So those are the most 5 common cancers in the United States. So let me step back a little bit, though, and talk to you a little bit about role of screening tests. And really, in order to do that, we really need to talk about these parameters. They are, number one is to detect asymptomatic and early stage disease. So if you don't have this, then there's no reason to screen anybody. There's no value in finding disease early. Number two is it should be highly sensitive and highly specific to pick up most cases of the disease and avoid false positives. Now, it's targeted towards the population with a higher disease prevalence, so there'll be a high predictive value, and it should be relatively safe and cost-effective, of course, right, because we have limited resources. It should screen for disease in which early identification and treatment have been demonstrated to improve clinical outcomes. So like I said, without that last piece, there's no point in proceeding with screening. So, having said that, how do we measure screening efficacy? Well, the first is the sensitivity. So the sensitivity, if you remember, is the chance that a person with cancer has a positive test. Specificity is the chance that a person without cancer has a negative test. A positive predictive value is the chance that a person with a positive test has cancer. And a negative predictive value is the chance that a person with a negative test does not have cancer. So those are the sort of four important screening efficacy parameters that we like to use. So in terms of cost effectiveness, and this is important to us in the United States because our healthcare costs are out of control. They consume 20% of our GDP, and I heard yesterday that for you it's around 6 or 7% of your GDP. So we are at 3 times the cost as you are here in Taiwan. And so cost is important to us. And so on the left is something that would cost minimally and be of high value, and on the right of the spectrum would be something that would be of very low value and yet cost a lot of money. So we want to avoid everything that's on the right and hopefully find something that's really on the left as far as screening tests are concerned. So let me show you cost effectiveness in terms of dollars. So for colorectal cancer, it's about $12,000 to $30,000 per year of life saved. For cervical cancer, it's around $5,300 per year of life saved. And for breast cancer in women over 65 years of age, it's about $56,000 per year of life saved. So these we would term as cost effective. These would be the screens that we would think are important to do, and they have value. Now, there are some common harms associated with screening. One is that you have false positive results. So the primary goal of screening, of course, is to find cancers and maximize sensitivity, but you have to have either a maximum sensitivity or specificity. It's very hard to do both. So when you have maximum sensitivity but not much specificity, then you end up with false positives. And that can lead, of course, to incorrect labeling, convenience, expense, physical and mental harm, and all the follow-up tests that you have to end up doing that really aren't really necessary because it was a false positive. So which are the cancers that are validated as screening? Colorectal cancer, certainly with colonoscopy, sigmoidoscopy, fecal immune testing, and occult blood testing. I'll go through each of these systematically. Lung cancer, low-dose helical CT scan in heavy smokers aged 55 to 80. Breast cancer, and of course mammography, and cervical cancer, Pap testing, and HPV testing. These are not validated screening modalities. So MRI for breast cancer in low and moderate risk women is not valid. Skin exams, believe it or not. We send a lot of people to dermatologists to do a general screen, a general examination, not of any value. PSA testing, and I'll show you that during the course of this talk. CA-125 in ovarian cancer, not a good screening test. Certainly CA-125 can be used to monitor the diagnosis of ovarian cancer, but not for screening. Breast self and clinical examinations have not been shown to be of any value. Now, women may do a self-breast exam and find lumps, but that's different than just pure screening. And we're not very good as clinicians for finding lumps either. and alpha-fetoprotein for liver cancer, and transvaginal ultrasound for uterine cancer. So none of these have been validated as good screening modalities. So the United States Preventive Task Force is really the guideline that we use for the most part. And do you use that here also? I think you may follow that to some degree. Let me just tell you a little bit about it. It was formed in 1984, and it has 24 members. They serve 4-year terms. They're mostly at academic medical centers, such as you have here. And they report to Congress on a yearly basis in terms of any changes that need to be made to their recommendations or any new recommendations that they may need to make. And they grade things. They grade things from A to D. A and B are services that they recommend. They think that they have value. C, it should be an individualized decision between the patient and the physician and the internist. And D is one that's not recommended. So something like prostate cancer screening, I'll show you, will be a D recommendation. So let me do the first cancer, and that will be colon cancer. And colon cancer in the United States is about 135,000 new cases a year and 50,000 deaths per year from colon cancer. It's the second leading cause of death in the United States. Now, screening with colonoscopy and other testing has decreased the rate of colon cancer by 30%. But the problem is that even in the U.S., we don't screen well. About 40% of people who are eligible for colon cancer screening do not get it. They just, for whatever reason, they don't get it. So, and we're recognizing that fact, and the U.S. Preventive Task Force has actually sort of changed its recommendation and said that any form of screening is good because we would like to raise the rates of screening to 80% by the year 2018. So very ambitious type of goal, but something I think that is achievable. So screening for colorectal cancer in average risk people, again, average risk, average meaning they're asymptomatic, they're older than 50 years of age, they have no personal or family history of colorectal cancer. And they should either get a colonoscopy every 10 years or get fecal occult blood testing or fecal immune testing with the sigmoidoscopy every 5 years, or a virtual colonoscopy. Now, in the United States, virtual colonoscopy is still not paid for by the insurance companies. It's still, it really is rarely paid for. So for patients who just can't tolerate a colonoscopy for whatever reason, we will go ahead and do a virtual. So screening in moderate risk people, and that's with a personal history of colorectal cancer, they should get a colonoscopy 1 year after their resection, and then they should get one in 3 years, and then one in 3 to 5 years. For polyps, if their polyp is less than 1 centimeter, the repeat is in 5 years. But if it's a large polyp, so greater than 1 centimeter, or many repeat polyps, then it's many polyps, then it's every 3 years. And then finally, if they have a family history of a first-degree relative with colorectal cancer, then they should be screened at the age of 40 or 10 years before the earliest case in their family. Now, there's another test called Cologuard. How many of you have heard of Cologuard? You have it here. Cologuard is a stool-based DNA screening test that we use occasionally in the United States. It's relatively new. It has reasonable specificity and sensitivity. And you basically take a stool sample and analyze the stool sample for any mutations in the DNA that would be a risk factor for colon cancer. Cologuard is only indicated for people at low risk, low or moderate risk. It's not indicated for people at high risk. So let me say that as far as colonoscopy is concerned, though, it's not without its own risk. There are about 4 perforations and about 3 bleeds in our population per 1,000. So it does have a not significant, but a rate of complications, and especially in people over 65, there's about 17 admissions to the hospital within 7 days of a colonoscopy per 1,000 people. So, so clearly, it's not a test without some risk associated with it. So the next category is, I think you're familiar with, is the high-risk hereditary non-polyposis coli, or HNPCC. And these are the Amsterdam 2 criteria. And in order to have this, you have to meet all 3 of these criteria. You have to have 3 or more relatives with HNPC-associated cancers, and you can see what those are. You have to have 2 successive generations of affected relatives, and you have to have 1 cancer diagnosis in a relative before the age of 50. So it's a rare cancer. I would say it is about 2 to 3% of colon cancers in the United States have this as their risk. So it's very rare. But the problem is that 80% of these people go on to have colorectal cancer. 80%. And the average age at which they get colorectal cancer is 40 years. So clearly, you need to start screening these people fairly early. So what do we do in terms of screening? Well, we definitely check them for genetic mutations with germline mutations such as Lynch syndrome, and we do a colonoscopy every 1 to 2 years beginning at the age of 25, or 2 to 5 years earlier than the youngest age of diagnosis of an affected relative if they're less than 25 years of age. And then we do a colonoscopy every 5 years beginning at the age of 40 years, or 10 years prior to the earliest family case for colorectal cancer or polyps in first-degree relatives before the age of 60, or if they have colorectal cancer in 2 or more relatives at any age. So, and finally, the colorectal cancer or adenomatous polyps in first-degree relatives greater than 60 years, or colorectal cancer in 2 second-degree relatives at any age, then the colonoscopy every 10 years beginning at the age of 40. So this is a very complicated scheme, and this is not one that you're going to see very much because, as I said, it's only 2 to 3% of the population, and I actually am not able to remember this either, so I actually have a little card that I use to remember this. Hopefully my slides will be available for you. I'm happy to submit them if you would like to have them. So there's another category, and that's called high-risk familial adenopolyposis, and that's FAP. And these individuals have more than 100 colonic adenomas. I mean, this is, again, fairly rare, but 100 colonic adenomas. And they usually have a family history, and they are at 70%. If they have between 10 and 100 adenomas in colonoscopy, they're about 70% risk of going on to having colon cancer. So these people have to be also screened from a relatively early age. Flexible sigmoidoscopy in children beginning at the age of 12, and then a repeat, if it's negative, a repeat annually until they reach the age of 40 years. And then at 40 years, they should actually get a prophylactic colectomy because their risk is so high of getting colon cancer that they really need to get that colectomy. And there, I think the rate is somewhere around 2 or 3 out of 13,000 live births get this disease. So let me move on to high-risk inflammatory bowel disease. So patients with inflammatory bowel disease for 8 to 10 years should undergo colonoscopy every 1 to 2 years. And remember now, this is important, ulcerative colitis beyond the rectum and Crohn's colitis involving at least less than 33% of the colon. So remember that they need to have significant involvement in order to be screened. Let me give you the first question, and that is, which of the following is not a United States Preventive Task Force recommended strategy for colorectal cancer screening in an average risk patient? Annual fecal blood testing and fecal immune testing, colonoscopy every 10 years, double contrast barium enema, fecal occult blood testing every 3 years, and flexible sigmoidoscopy every 5 years, or flexible sigmoidoscopy every 5 years. So how many would answer A, B, C, and D? Okay, so most of you got that correct. The answer is C, as I just showed you on the previous slides. A, B, D, and E are acceptable screening mechanisms by the U.S. Preventive Task Force. Barium contrast is not. We rarely do that anymore, only in people who really are intolerant, or we just couldn't get the colonoscope all the way around to the right side. Then we would do an air contrast barium enema. So the correct answer is C, air contrast barium enema. So which of the following is the time to initiate colorectal cancer screening in a patient in whom a first-degree family member was diagnosed with colorectal cancer at age 48 years of age? 38 years, 40 years, 48 years, or 50 years? How many would say 38 years? Any for B? Any for C? And any for D? So you're again correct. 38 years is the right answer. You want to start screening people who have a family member 10 years earlier than the age of that family member. So in this patient, it would be 38 years. And otherwise, it would be 40. But in this patient, it would be 38 years. So let me move on to the next question. So you can read that. And it's a 38-year-old woman is evaluated in follow-up after recent surgery for endometrial cancer. Her family history is significant for colon cancer, and her sister diagnosed at age 45, her mother diagnosed at age 65, her maternal grandfather was diagnosed with rectal cancer at age 47, and the patient's never had a colon cancer screening and colonoscopy. So let me go on to ask, which of the following is the most appropriate time to start colon cancer screening with colonoscopy? Now, 40 years, 47 years, or 50 years? How many would say now? Right. Any for B, any for C, and any for D? So that's great. Yeah, so you would start screening this patient now, because I just gave you a slide on this syndrome, which is the HNPCC syndrome. That's what this patient has. And so she needs to be screened now, because her risk, as I've shown you from the previous slides, is extremely high of getting colon cancer. So very good. Well, you guys are paying attention, or you know a lot even before you heard all of this. So let's see, a 42-year-old man has confirmed ulcerative proctitis with no abnormalities seen in the sigmoid or proximal colon on 2 examinations 8 years apart. Which of the following is most appropriate colon cancer screening strategy for this patient? Colonoscopy at age 50, and then another 8 to 10 years, colonoscopy in a year, and then annually, colonoscopy in 15 years, and then every 8 to 10 years, or a colonoscopy every 8 years, and then annually. So, how many think the correct answer is A, B, C, and D? Okay, so this is more difficult, but this patient could get a colonoscopy at age 50 and then every 8 to 10 years. The correct answer is A, because if you remember, this person has ulcerative colitis, but he does not have any abnormalities involving his sigmoid or proximal colon on 2 examinations. So his risk is relatively low. Okay, so again, if you have a large part of your rectum or colon involved with ulcerative colitis or Crohn's disease, then your risk is much higher, and you would need to have one of the other options. But for him, and this is sort of a trick question, for him actually, he can wait till he's 50 before he gets his next colonoscopy. So, which of the following is the recommended frequency of colorectal cancer surveillance colonoscopy in a patient with long-standing 8 to 10 years of inflammatory colitis? So this is a little bit of a different patient. And then this patient should go 1 to 2 years, 4 to 5 years, 7 or 8 years, or 10 years. How many would say A? Right, B, C, or D? So again, the answer here is A, 1 to 2 years, because these patients do have a higher risk of colon cancer, and so these patients should be screened in 1 to 2 years. So the correct answer would be A, because they have involvement of the rectum and a third of the colon. So let me move on to lung cancer screening. Lung cancer is the most common diagnosis as far as cancers is concerned. It causes 160,000 deaths per year in the United States. the U.S. Preventive Task Force has made this a grade B recommendation. So it does recommend lung cancer screening. And it recommends it for adults with a history of smoking, and annual screening for lung cancer with low-dose CT in adults aged 55 to 80 who have a 30-pack a year smoking history and currently are a smoker or have quit in the past 15 years. So they need to meet all of these criteria, and if they've discontinued after 15 years, then you can smoking, then you can stop screening. So remember, it's between 55 and 80, and it's for 30-pack a year smoking history, and if they've quit within the past 15 years. So here's a 59-year-old man is evaluated during a health maintenance visit. He's asymptomatic. He has a 35-year pack smoking history, but he quit smoking 5 years ago. He takes no medications. Vital signs and physical exam are normal. So which of the following is the most appropriate screening test to obtain? Abdominal ultrasound, chest x-ray, low-dose CT, or spirometry? How many would say A, B, C? Right, and D. So clearly low-dose CT is the right answer. I just gave you the answer on the previous slide. Abdominal ultrasonography we do in smokers between the age of 65 and 75 who have been smokers for at least 100 pack year. So 100 cigarettes total in their lifetime. Chest x-ray, there's no screening reason to do a chest x-ray, and there's no screening reason to do spirometry. So if you're going to screen, you need to screen with low-dose CT. Let me move on. So which of the following groups of patients in good health are most likely to benefit from low-dose CT lung cancer screening? All cigarette smokers, all smokers aged 55 to 80 with 30-year pack history, all cigarette smokers who have quit within the previous 15 years, or male smokers 55 to 80 with 10-pack a year history of smoking. So how many would say 1, 2, 3, and 4? Okay, so you're correct. I mean, we just went over this, so this really is all cigarette smokers in that category would be eligible for screening. And finally, for lung cancer, which of the following approximates the percentage of resections that are performed for benign disease in patients participating in lung cancer screening trials? 1%, 20%, 50%, or 75%? So how many people would say A, 1%, B, 20%, C, 50%, and D, 75%? So a little bit of a mixture on that. And the answer is that the Pittsburgh lung screening trial had a rate of around 30% of benign findings on lung cancer screening when they actually did thoracoscopic biopsies. The National Lung Cancer Screening Trial had 27%. Another trial done in Canada had about an 18% benign nodule rate, or false positives in a sense. So the average turns out to be around 20%. There was an Italian trial that was also around 20%. So 20% of what was thought on lung cancer screening that was thought to be benign, that was thought to be possibly malignant nodules, turned out to be benign nodules. So 20% false positive rate with lung cancer screening. Fairly high rate, but we nevertheless do recommend it in those subset of people that we've just been talking about. Let me move on to prostate cancer screening, and I could probably sum up prostate cancer screening just by this one slide right here, and that is it really involves a discussion between you and your patient. There are really no definite recommendations about prostate cancer screening. The harms of prostate cancer screening outweigh the benefits of screening. The cost of screening is about $5.2 million to prevent one death from prostate cancer. If you remember, the cost for colon cancer and breast cancer was in that $30,000 to $40,000 to $50,000 range. This is in the $5.2 million range. And one treatment of a disease, it's a treatment of a disease with low risk, and really people who are older are unlikely to die of the disease. So it really doesn't meet the criteria for screening. And the problems are in the United States that even the surgeons who do prostatectomies do very few. Individually, they do about 3 prostatectomies per year. So their rate of complications is fairly high. And those complications include bleeding, incontinence, erectile dysfunction, infection, overdiagnosis, and even death. So not recommended. So there are 2 studies. The European randomized study for screening prostate cancer that showed no survival benefit, and the prostate, lung, colorectal, and ovarian trial also showed no cancer-specific survival benefit. So the ACP guidelines are really to inform patients of possible benefits and significant harms of PSA testing. No testing for those who do not express a clear preference for screening. No PSA testing in anyone under the age of 50. No PSA testing for anyone over the age of 69, and no PSA testing if the life expectancy is less than 10 to 15 years. So it's a very narrow group of patients that may be eligible for screening for prostate cancer. The Canadian Task Force on Preventive Health said age less than 55, greater than 70, no screening. 55 to 69, they said a weak recommendation against screening. I don't really know what that means even. Clinicians should not routinely discuss screening unless brought up by the patient, is what they say. So they say don't even bring it up. You know, if the patient asks, you can talk about it, but you don't need to bring it up because there's no reason to. And those who have a high value on but a small potential reduction, if they really want it, may choose to be screened. So which of the following is the U.S. Preventive Task Force recommendation for prostate cancer screening? Evidence is inconclusive. To recommend for or against, recommend against, recommend for, or recommend shared decision making. A, B, and C, or D. Okay. Oops. What happened there? Yeah, so the correct answer is actually B, recommend against PSA-based screening. If you remember, both the American College of Physicians and the U.S. Preventive Task Force do not recommend screening patients by PSA testing. So which of the following is most consistent with the American College of Physicians guidance statement on prostate cancer screening? And I think I gave you the answer here. Also, avoid screening with a life expectancy of less than 10 to 15 years, screen eligible men annually, screen patients between the age of 50 and 75, and screen using prostate-specific antigens. So clearly the answer here is avoid screening if your life expectancy is less than 10 to 15 years. There's no value to it whatsoever. So a 52-year-old man is evaluated during a periodic health exam. He has BPH, and his father died of prostate cancer at 74. His only current medication is tamsulosin, and he has no urinary symptoms. His vital signs are normal, and the remainder of his physical exam is normal. So which of the following is the most appropriate management? A, discuss the risks and benefits, obtain a PSA, perform a digital rectal exam, perform a digital rectal, and obtain a PSA. So who would do A, B, C, and D? Okay, so most of you got that right. Discuss the risks and benefits of prostate cancer screening. So again, just from what we've been talking about for the last couple of minutes, there's really no shown evidence to say you need to get a PSA test. Discuss it with the patient. If they have a high level of concern, you may want to go ahead and get it. There is really no evidence that a digital rectal exam and a PSA combined increase your sensitivity or specificity for detecting prostate cancer. So believe it or not, we do these every day, right? We do tens of them every day, but there's no real value in that. So some surprises there. So basically the bottom line on prostate cancer is really you don't need to screen. Breast cancer, first mammography recommendation was made in 1976 by the American Cancer Society to start screening with mammograms. So the first well, we have 23% of all cancers in women that are in the United States, and U.S. women's lifetime risk of getting breast cancer is about 12%. Now, their 10-year risk of invasive breast cancer is about 15% at age 40. At age 50, it rises to 23%. At age 60, it's at about 35%. And in 2016, we're going to have 250,000 cases of breast cancer and 40,000 deaths in the United States. So this is a significant problem, and this is one that's important to screen for, and especially in that third category of age 60 years and 60 to 69. So here are some risk factors as far as breast cancer is concerned. You can see that if they have had mantle radiation, the risk is, or chest radiation, the risk is very high, and these people definitely need to be screened. But even people with extremely dense breasts, those women also should be screened because their lifetime risk is around 4.5 higher. If they've had a history of atypical hyperplasia, they're at 3.7. If they've had 2 first-degree relatives, they're high at 3.5. 1 first-degree relative, 2.5. If they had menopause after 55, or they have nulliparity or first pregnancy age 30 or older, then they're at higher risk. And then going on down the line, you can see that some of these others are not don't really increase the risk that much, including postmenopausal obesity and also the use of estrogens. So they do to some degree, but not to a significant degree. So, and here is the risk index based on density, and you can see that women around 65 who have extremely dense breasts or who have heterogeneous dense breasts are certainly at higher risk. So you will definitely want to screen these folks. And then this is again risk ratios for cancer mortality, and you can again see it's saying the same thing, that women really in between 60 and 69 really are at the highest risk, with 21 deaths prevented every 10 years if we do perform screening. A little less for women 70 to 74, but really in women in their 40s, there's really no value to screening. So again, as I mentioned earlier, the breast self-exam really shows, the randomized trials show no benefit to decreasing mortality. Women may palpate lesions, but it doesn't decrease, it's not really the case on routine exams. As far as the clinical breast exam is concerned, there's again a high degree of variability. We all do breast exams differently. We all have our own way of doing them. There's no standard exam, so it's not recommended by the U.S. Preventive Task Force. So for screening women with normal risk, the U.S. Preventive Task Force says is against the breast self-exam or the clinical breast exam. They recommend digital mammography, age 50. Let me just move to that slide here. So you can read that slide on your own. So the recommendation, as you can see, is age 39 to 49 against screening because of just the reasons that I mentioned earlier, and age 50 to 74 biannual mammography. Age 75 or greater, there's really not enough evidence. There haven't been enough studies done really to show any benefit. The National Comprehensive Cancer Network says age 20 to 39, they do recommend a clinical breast exam for every 1 to 3 years. 40 to 69, they say breast exam and annual mammogram. So they recommend 40, but Preventive Task Force does not. And greater than 70, they say 1 to 2 years, depending on the clinical setting. And I'll show you a couple of others. If we move to American Cancer Society, they say they're a little different. They say age 45 to 54 for annual mammogram, and then age 55 to, they question when to stop screening. They say biannual mammography. They say continue screening as long as overall health is good and life expectancy is greater than 10 years. So breast cancer risk assessment beyond average risk, that is someone who has a personal history of DCIS or invasive cancer, history of radiation at age less than 30 years, BRCA1 or 2 mutations, a family history of breast or ovarian cancer, lobular carcinoma in situ, a prior breast biopsy, or hormonal factors like early age of menarche or later age of birth or late menopause or hormone replacement for greater than 5 years does increase your risk beyond average. And then there's the women who are at very high risk, and those are the women with high risk hereditary predisposition, BRCA1 and BRCA2 mutations. And these women should be screened annually, starting with MRI and mammography at age 25 or the earliest onset in the family, and they should even be considered for risk reduction surgery. And Angelina Jolie, I think, is the most famous example of a woman who did get a bilateral mastectomy at age 40. In men, much less common, and they're recommending at least age 40 and annually thereafter. As far as digital versus film, I mean, here you probably don't have any film now. Do you all digital mammography for the most part? In the United States, we do. It's about 90% digital. Digital is better under age of 50 for heterogeneous or very dense breasts and for pre and perimenopausal women. Now, the new modalities, do you have 3D tomosynthesis? We are beginning to use it, but it does expose you to 2 times the amount of radiation, and there's really no benefits over standard or digital mammography for average or above average risks of women, and even in dense breasts, a mammogram with ultrasound may be just as equivalent. So MRI is the other new modality, and again, it's really poor for flow-dependent cancers such as ductal cancers. It has no effect on mortality. There's a high cost associated with it, and the U.S. Preventive Task Force does not recommend MRI as a screening mechanism. So here's the next question. A 75-year-old woman is evaluated during a follow-up exam, and you can read the rest of it. While I catch up here. So, on physical exam, the patient is at febrile, blood pressure is 142/76, and you can read that she's got an AV hemodialysis graft in place. The remainder of her exam is unremarkable, and the last mammogram was a year ago, and it was normal. So the question is, which of the following is the most appropriate management of this patient's breast cancer screening? Begin screening with breast MRI, continue annual mammography, switch to biannual, or discontinue breast cancer screening. Somebody would say A, B, C, or D. Correct. D is the right answer. This is a woman who's on hemodialysis. Her life expectancy on hemodialysis is less than 3 years. She would not be someone who would you want to screen for breast cancer. She doesn't have a 10-year life expectancy. So here you have a 38-year-old woman who undergoes routine follow-up evaluation. The patient was treated with mantle radiation for stage 2A Hodgkin's lymphoma at age 19. She's done well and has no evidence of recurrence. Personal family histories are non-contributory. Exam is normal. She does not have any lymphadenopathy. You can read through the rest of it. Recent imaging studies, no recent imaging studies have been obtained. So which of the following is recommended cancer screening for this patient? Begin annual mammogram now, annual mammogram and MRI, begin annual mammogram at 40, or begin monthly breast self-exams? A, B, C, and D. Okay, so the correct answer is actually, it's a little trick question, but begin annual mammogram and breast MRI now, because these women, if you remember, have a very, very high rate of breast cancer, 26 times the rate of the average woman. And here's actually an indication where the 2 tests of annual mammogram and MRI are actually complementary. So these women should get both MRI and mammogram. So one of the rare occasions where we actually use MRI. So this patient here, I think we may be able to skip over in the interest of time. So a 42-year-old woman is evaluated during a routine exam. She underwent, menarche age 14. You can read the rest of it. Heterogeneous dense breasts. the mammogram is otherwise normal. Which of the following imaging modalities is the most appropriate for subsequent breast cancer screening in this patient? Breast MRI, digital mammogram, film mammogram, or whole breast ultrasound? A, breast MRI. B, digital mammogram. Yep, film and whole breast ultrasound. So, as I said, there's really no reason to do film anymore. Digital is superior, and this woman would simply need a digital mammogram. Breast MRI not indicated in this patient. Certainly ultrasonography would not be helpful. So let me move on to the last cancer that I wanted to cover, and that is cervical cancer screening. So George Papanicolaou actually discovered in 1923 the Papanicolaou smear, and it was actually used in the first time really in 1960 as a screening mechanism. And it has decreased the rate of squamous cell carcinoma for cervical cancer by 70%. 70%. What's interesting is that the rate of adenocarcinoma of the cervix has not been decreased and actually has been increasing. So the Pap smear is good for squamous cell, but not so good for adenocarcinoma. And in the United States, there's about 13,000 new cases per year of cervical cancer and 4,200 deaths per year. So the U.S. Preventive Task Force says women 21 to 65 years, and this is complicated again, women 25 to 65 years should have a Pap smear, or if they're 30 to 65, in combination with HPV testing. Women 21 to 65 should have a Pap smear every 3 years, and women 30 to 65 may increase screening interval to 5 years for Pap and HPV testing. So women younger than 30 should have no HPV testing, and women younger than 21 should not be screened at all. And women older than 65 or who've had a removal of their cervix should not be screened. So let me move to, I believe it's the next question. So here you have a 26-year-old woman who's evaluated during a routine exam. Her last Pap smear was performed 1 year ago and was normal. She's received a complete HPV quadrivalent vaccine series. The medical history is unremarkable. Family history is non-contributory. Takes no medication. Exam's pretty normal. So which of the following is the most appropriate management of this patient's cervical cancer screening? Obtain HPV testing in 2 years, Pap smear in 2 years, Pap smear and HPV testing now, or Pap smear and HPV testing in 2 years. So how many would say A, B, C, and D? So most of you got that correct. The answer is B. The patient should receive a Pap smear in 2 years because she just had one a year ago, so she'll need one at year 3, and she's between the age of 21 and 65, and so she should receive that screening. And let me move on to the next. 65-year-old woman is evaluated during a routine exam. She's asymptomatic. Her most recent cervical cancer screening was 2 years ago at the age of 63, included a normal Pap. She's received regular Paps for the last 30 years. And you can read the rest of it there. She takes no medications. Her physical exam is unremarkable. So, which of the following is the most appropriate for cervical cancer screening in this woman? Obtain a Pap in 1 year, Pap in 3 years, obtain a Pap now, or discontinue screening. So me would say A, B, C, and D. Okay, so most of you got that right. The correct answer is discontinue screening. So this woman is 65 years old. Her risk of cervical cancer is very low. She's been having Pap smears all along. She just had one last year. There's really no reason to continue cervical cancer screening in this age group. So 65 and over in this age group, you can discontinue. So the take-home advice is stay current on your screening recommendations. Follow a guideline and document what guideline you're following, but also talk to patients about their individual risk because it really becomes in the end a shared decision-making type of decision, and we do that a lot, and that's the emphasis in the United States, is to really talk to your patients about these guidelines and about anything else and come to a common decision on what you want to do. So with that, I'll thank you very much, and I'm happy to take any questions.
Thank you, Professor Damle, for very informative presentation. Is there any question to Professor Damle? 请开的那个自开，全部开。
Thank you very much for your comprehensive introduction of the US. I found that the US system is much more less frequent than that we practice in this country, probably due to the higher cost in your country. And my question is, if you schedule a patient 2 or 3 years to have a pap smear, and before that time she got really cancer, then is there some cases will be a legal problem in your country?
Again, that's a good question. If you follow, and that's why I point out in this take-home message that if you follow a screening guideline and you document that that's the screening guideline that you follow, then if they do develop cancer before the next screening interval, you have a pretty good case. That doesn't mean you won't be sued, and in the United States we like to sue. So you may be sued for that, but you will be in court. I think you'll be on solid ground if you follow guidelines. Yeah.
I would like to ask another question. Initially you mentioned about the PV testing for screening, but in fact, I think you do not recommend to use virus testing for screening of cervical cancer. And the second one, no, I understand you do not quite catch my point. What is the place of testing PV virus, HPV?
Oh, HPV.
Yes, okay. How about the place to test human virus for screening of cervical cancer? This is number one. Number two, do you have special program for cervical screening for the Jewish lady?
Oh, for Jewish?
Yes.
Yeah, because they have a higher rate.
No, they have lower rate.
They have what?
Because they have lower rate.
They have a lower rate. No, I don't think we discriminate as far as that's concerned. No.
So I would like to understand what is the purpose of testing human virus for screening of cervical cancer?
Well, the HPV is one of the leading causes of cervical cancer. As a very, if you're HPV positive, you have about an 80% chance of going on to having cervical cancer. So you need to be screened for that. So it's very important in women age 21, actually in women age 30 and over, to regularly be screened for HPV. Now, women age less than 21 may have HPV, but they're not at risk because they're so young. They haven't had it for very long. Women aged 21 to 30, interestingly enough, may have HPV and may clear their HPV and will have a decreased risk for going on. But if you're over 30 years old, you have HPV, you have a pretty high risk of going on to getting cervical cancer. In fact, cervical cancer is almost unheard of in women who haven't had HPV positivity in the past.
To my knowledge, HPV have many strains, and do you test all the strains or selected how many strains you test?
Yeah, so the vaccine series, there's different vaccines. There's the HPV, there was a 2, then there's a 4, and now that was the quadrivalent, and now there's even a 9 strain vaccine. And so the ones that we recommend are the 4 and the 9. So either one of those is perfectly fine. But it's a series. It's not just one shot. It's a series of 3 shots that you have to get at 0, 6, and 1 year. Generally now we use the 9 different strains of HPV. So that protects against like 90 to 95% of HPV-related cervical cancer. The 4 is pretty good. It protects against 80 to 85%.
And another problem is usually the recommendation for vaccination for HPV should be done before age 12. That means after age 12, probably most ladies may have positive HPV test. So I think it's very difficult to interpret the result of the test.
Yes, I'm not sure I'm. Was that a question?
One more question.
Yeah.
This first. Oh. Yeah, okay, please.
For the screening of lung cancer with low-dose CT, do you have any long-term evidence to balance the cost effectiveness against the long-term safety with radiation or those low dose?
Yeah, so with low dose, it has been shown to be efficacious because there's about one case of lung cancer prevented for every 300 cases that are screened. So for the cost associated with that, it's somewhere around $60,000 to $70,000 per quality life year. So that's a reasonable amount of money.
I mean the irradiation with the low dose.
Yeah, the low dose radiation does not seem to increase the risk of lung cancer.
Okay.
So it's a low enough dose that it seems
Okay,
to
thank you. My second question is with regards to the screening of prostate cancer. I heard from urologists several years ago they recommended to screen PSA yearly, and you don't check one single point, but you observe the trend of the change of the PSA. If it is increasing gradually, then that's a very high risk for prostate cancer. So do you recommend, although you don't recommend screening with PSA, but is it possible to screen the patients with symptoms of PSA yearly? And
Yeah. I think once you start screening, once you get that initial PSA, you're stuck, right? So then you've got to get another one a year later or 2 years later. And so the first one might be 3.0, and then the next year is 4.5. So it's higher than the cutoff. We use a 4.0 as our cutoff. For anything under 4.0, we consider to be very low risk of a problem. Over 4.0, and if the previous one was 2.0, and the next one's 4.5, then you've got the velocity, and you've got one that's over 4, then you're stuck. Then you've got to go to a prostate biopsy. You don't have a choice. And so that will be a case where, if you did do a prostate biopsy, and someone who went from 2 to 4.5 in a year, you might get sued and you might lose. So then you're not screening anymore. Then you're stuck. So that's why you don't start the process. Because once you do, then you're stuck.
my last question is, what's the point of view on the screening of pancreatic cancer, especially in the high-risk patients, like diabetes patients, because I know that there is some controversy and some argument for and against screening pancreatic cancer.
Pancreatic cancer?
Pancreatic cancer.
Yeah, we have no screening tests with that. The U.S. Preventive Task Force or any other American College of Physicians, American Cancer Society has no recommendations for screening for pancreatic cancer because it's not been shown to be specific or sensitive either by ultrasonography, by CAT scan, or by MRI, unfortunately. And there's no blood tests. There are blood tests in development right now, but nothing that's been shown to be a good screen for pancreatic, unfortunately, for pancreatic cancer, even in diabetics.
One more question, you're allowed only because of time limit.
Excuse me. My question is, if you do the first screening and it's in a high-risk patients and it shows negative results, do you change the subsequent strategy of screening? My meaning is, did that decrease her relative risk of getting a cancer? If you didn't change the strategy, then the burden of the screening population will increase year by year.
I think you still have to follow the screening recommendations that I talked about. So you start screening depending on the cancer, which cancer you're talking about, depending on the risk of the patient. in terms of whether they fall in at average risk, higher risk, or very high risk. And if they are at high or very high risk, then you have to follow those guidelines. Like for colon cancer, for HNPC patients, they need to get a colonoscopy every year. And you don't change that as you go through the years with them. You stay with the guideline. You don't modify the guideline for an individual patient.
Okay. Thank you, Professor Damle.
What is negative screen test? Modify your predict your subsequent risk. It change your subsequent risk. If one negative screen, 2 or 3, because if that does not reduce the chance relative risk, then the population you screen will increase.
Yes, that's yeah.
Turn out the screening task force.
Yeah. Well, I mean, if you have a series of negative tests, I still think that I think that's what you're saying, is maybe you should stop screening because the risk is going down and you don't need any further screening. But I think that you still should follow the guidelines, even if you have had a series of negative tests. I think that you'd be better off sticking with that than just stopping screening.
Okay. Thank you. Because of the pandemic, I have to close this topic. On behalf of the society, I will send a break to Professor Damle.
Oh, another guy. Okay, thank you very much. Oh, this is beautiful.
And the second topic